Hello, dear doctors. We are here today to discuss a very important topic that you may find in BASIS exam and MRCB exams also. It is about headache. You may find it in station number 2 or station number 5 or the new way of the exam models that we are anticipating to be applied soon in station number 5 long cases. So let us go and explore more and more about this important topic. Headache is considered as a symptom of pain in the face, head, or neck, and it may be different from one to another, with a different presentation or different symptoms, even in the same diagnosis. Headache is considered as a sign for an underlying cause or an underlying disease, so it is not a diagnosis. Headache is classified according to the cause into three big categories. The first category that we will find is an acute sudden causes or chronic causes or headache that comes in attacks. I put a black dot beside the important diagnoses that you may find in BASIS exam. So let us explore about these topics. The acute sudden causes, the first and the top of these causes is subarachnoid hemorrhage, which is the most emergency one, subdural hematoma, meningitis, encephalitis, sagittal sinus thrombosis, and giant cell arteritis, and pituitary apoplexy, and hypertensive emergency or hypertensive urgency, or even stroke. The chronic causes: tension headache, medication overuse, that we mean analgesic abuse mostly, trigeminal neuralgia, and the patient, when you asked him about the pain character, he is telling you that it is an electric like shock which is present in the face. Idiopathic increase intracranial tension, and it is a very common idea in the exam. Chronic hypertension and anemia, and don't forget about the causes of the chronic hypertension, pheochromocytoma, and brain tumor or metastasis. Okay, headache which usually comes in attacks, usually there are four ideas: migraine, cluster headache, paroxysmal hemicrania, and pheochromocytoma that may cause a pain or headache and fear and anxiety which comes and goes in attacks. History taking in case of headache is extremely important. The onset, the course, the duration, and what makes it increase and what makes it decrease, and the associated symptoms. The first time to occur or occurred before is very important, and you should ask him, have you been diagnosed by any medical illness or on a long-standing disease or not? Very important to ask him, did you suffer from a trauma or fall, to get a diagnosis of subdural hematoma or something like that. Character of the pain is very important, especially is it band-like or dull aching, or you feel that it is electric-like shock. The site is extremely important. Is it unilateral or global over your head? And the radiation, is it radiating to anywhere? And the pain score from 0 to 10. Let us simulate that 0, no pain at all, and 10 is the maximum pain that you can ever feel. You should ask him if it comes in attacks, and if he told you yes, so the attack today is similar to attacks before or not, because it may change totally your diagnosis. Very important to review of the neurological system symptoms. and ask about red flags because this can change your view of the diagnosis. Let us go and look for the clues of headache, the clues which you may find in case, and try to pick up, and let us go and explore more clues that can change your view of the diagnosis, and we will take it step by step. Let's go. The first important topic that we'd like to talk about it is migraine, and there are important features of migraine in the form of unilateral headache, which comes in attacks. And the classical attack of migraine, it remains for from 4 to 72 hours, not more than that, and may be present with other neurological symptoms like aura, and aura is a visual symptom, and double vision may occur, or even weakness, and it increase with a certain precipitants, and you should ask about the precipitants that may lead to migraine. And there are most important types of migraines that you will be asked about it in the exam, or you will find cases about it, is hemiplegic migraine, and also ophthalmoplegic migraine, and also migraine with aura. There are 7 types of migraine: migraine with aura, migraine without aura, and aura without migraine. And there are also basilar migraine, which can present as a double vision problem in swallowing and unsteadiness, and ophthalmoplegic migraine, that the patient when suffer from it, he is unable to look to any side. Okay. And hemiplegic migraine, it can present as a weakness. Okay, and the differential diagnosis of it, stroke, and your workup will depend on exclusion of a stroke, which may mimic hemiplegic migraine, because migraine is a risk factor of increasing stroke. Okay, and there is also vestibular migraine, that the patient may suffer from some sort of ear symptoms, like ringing in the ear or ear fullness during the attack of the headache. These are the types of migraine but the most important of them is migraine with aura, and hemiplegic migraine, and ophthalmoplegic migraine. The examiner may ask you, and you should know the precipitants of migraine. And the precipitants of migraine are stress, lack of sleep or sleep disturbance, high tyramine diet, example, old cheese, premenstrual also, drinking of alcohol. And you should advise the patient about moderation or stopping of alcohol. Moderation is drinking as less as possible, because it may increase the attacks of migraine. Highlights or high sounds, all of this considered to be risk factors and precipitants that you may suffer from attack of migraine. So if you have migraine, you should avoid all of that. The important question is how to manage migraine. Migraine, there are important things that you should follow to control the number of the attacks. First of all is lifestyle modification by avoidance of all the precipitants that we listed before. And for females, also avoidance of oral contraceptive pills, because there are a lot of theories that the hormonal fluctuation by an oral contraceptive pills will increase the attack of migraine, and it is confirmed. So avoidance of oral contraceptive pills. Migraine also is known to increase the incidence of occurrence of stroke. Receiving oral contraceptive pills may increase this incidence, and it is very important to avoid it. Management of the acute attack by giving paracetamol with sumatriptan or non-steroidals with sumatriptan. If there is any weakness or lateralizing symptoms, you should do CT scan to exclude a stroke, because migraine increases the risk of a stroke. There is a prophylaxis therapy for migraine if there is a recurrent attacks of migraine. And the prophylaxis therapy is given for the people who are suffering of 2 or more attacks per month. And the first line and the most important line is beta blockers with a propranolol dose may range from 80 milligram to 240 milligram. But the trap here, you should ask about if the patient is having asthma or not, which is very important. Other agents like sodium valproate, topiramate, amitriptyline, and I wanted to tell you also there are a new rule for botulinum toxin injection, which can help. Okay. The second clue for us will be about subarachnoid hemorrhage. We call it thunderclap headache. Patient may tell you that this is the most worst headache that I suffered in my life. I felt that someone hit me with a heavy object, or I received a thunderclap in my headache. And usually the pain score of it is usually high. And as I told you before, if the patient may come to you with a recurrent attacks of headache, you should ask him about the last attack, or the attack today is similar to attack before. He may tell you no, and the patient may be diagnosed with migraine and he is coming to you with another attack, and it is very severe headache, and the diagnosis may be subarachnoid hemorrhage. And subarachnoid hemorrhage, the patient may present it for you with increased intracranial tension, like headache increase with leaning forward, or symptoms of sense of sickness and throwing up and vomiting. And you should ask about all of that. You should ask about any disturbance in conscious or loss of conscious, and very important. You should ask also about trauma. Did the patient suffer from any trauma or not? Before suffering from this headache, did he strain or severe cough or sneezing? All of this is considered to be important. This is a typical CT. As we see, the arrow is showing there is a blood diffusing through the ventricles, and this is a subarachnoid hemorrhage CT scan. Management of subarachnoid hemorrhage, very important question. First of all, you will do and will ask for doing an urgent CT brain. And if it is negative and still suspecting it, you should go for a lumbar puncture after 12 hours to look for a xanthochromia. Urgent admission in the intensive therapeutic unit. Putting the patient in a semi-sitting position, and ask the patient to avoid straining, coughing, or sneezing. All of this is very important. Call for help from the neurologists and the neurosurgeon. They can give a medicine which is called nimodipine, which is a calcium channel blocker, will work on cerebral blood vessels to avoid cerebral ischemia. And they may arrange for doing a neurosurgery to look for aneurysm, or they can apply coils. Sagittal sinus thrombosis, one of the common cases that you may find in your exam. Sagittal sinus thrombosis, there are cerebral veins which are draining the brain. Okay, and this cerebral venous thrombosis stop the drainage of the brain. This headache is dull aching, may be unilateral or diffuse. The patient may suffer from headache which is increasing, and there is an abnormal vision, symptoms of increased intracranial tension, and the headache is usually progressive and not responding to analgesics. It is a very important thing that you should think about sagittal sinus thrombosis because it is very common. Okay, so clues which will make you suspect sagittal sinus thrombosis. It is more common in females, especially pregnant, because pregnancy may increase the hypercoagulable state, or using of oral contraceptive pills, as oral contraceptive pills may increase the coagulation tendency. History of recurrent abortions of DVT. Recurrent abortion may give you a clue about antiphospholipid syndrome. Diseases which will or may lead to increased incidence of thrombosis like Behçet disease, antiphospholipid syndrome, abnormal protein C and S, and recurrent thrombosis elsewhere. Presence of blood diseases. You should ask about the blood diseases like sickle cell anemia, polycythemia rubra vera, paroxysmal nocturnal hemoglobinuria, like any tummy pain before and after it in the early morning, reddish or dark colored urine is very important, and thrombophilia. All of this is considered to be very important. You should ask also about family history of blood disease or clots in the family. The investigations you'd like to do for a sagittal sinus thrombosis is first CBC with a blood film and complete thrombophilic screen. MRV is very important, and doing a fundus examination, because fundus examination will show for you early papilledema signs. The management is avoidance of the risk factor, for example, oral contraceptive pills. Admission of the patient. Heparin or low molecular weight heparin in the initial treatment, followed by warfarin, provided there are no other bleeding risks that would make these treatments unsuitable. Continue treatment of the cause if you find the cause, so at that time you will continue according to the protocol of the treatment at that time. This image show for us MRV with a sagittal sinus thrombosis, and the arrow show for you there is a stopping and partial obstruction here by a thrombus, which is stopping the drainage of the brain and blocking it, as you see. Another important idea about unilateral headache, two differential diagnoses which we can have, like cluster headache or paroxysmal hemicrania. So the most important thing is how to differentiate between both of them. Both of them can present as a unilateral headache and the presence of a vasomotor symptoms. What is the vasomotor symptoms? Like stiffness in the nose or blocking, or unilateral rhinorrhea. Maybe the patient suffer from a dropping of the eyelids or a swelling of the eyelid, which is unilateral, also on the same side of the headache, and maybe there is a redness of the eye, okay, or excessive tearing of the eye. All of this is considered to be very important, but both of them are so near. So how can you differentiate? Can you give me the clues more? Yes. The cluster headache is lesser in the number of the attacks and more longer, but the paroxysmal hemicrania is greater in number in the attacks but more shorter. I mean that if the attack of headache is exceeding more 1 hour, so it will be mostly cluster headache. Paroxysmal hemicrania usually comes in attacks, but it is more shorter. The management is completely different between both of them. In acute attack, usually in cluster headache, we give oxygen and nasal nasal neglocaine or subcutaneous sumatriptan, and the prophylactic treatment to avoid recurrence of this headache is verapamil, and we can start it by a dose and initiate it by a dose verapamil 40 milligrams, maybe twice daily. Treatment of paroxysmal hemicrania is indomethacin, which is definitive and can stop this headache. New idea about the differential diagnosis of headache with increased intracranial tension. First of all, what are the features of increased intracranial tension? The increased intracranial tension is dull aching headache, worse by bending forward, worse with cough and straining or sneezing, okay, associated with a morning sense of sickness or throwing up, worse in the morning and improves through the day. All of these considered to be features of increased intracranial tension. The differential diagnosis of causes of headache with increased intracranial tension. First of all, pituitary adenoma. Pituitary adenoma, like cases of acromegaly, prolactinoma. So it causes a headache with an increased intracranial tension. And if the patient has a visual symptoms with this headache and increased intracranial tension, so it may brain growth or pituitary growth, which is compressing or start to affect the optic chiasm. So you should ask him about do you have any problem of vision, the periphery or the sides of the vision, can you see it clearly, do you bump the objects while walking or driving. All of this is very important. Brain tumor or metastasis, previous history of for example breast cancer, and she is coming to you today with increased intracranial tension headache. Okay, it is a very common idea. Or brain tumor, you should ask also about weight or a change in the appetite. All of this considered to be important. Idiopathic increased intracranial tension, very common idea in the exam, subdural hematoma, and you will know it by a previous history of trauma. And after that, the patient started to suffer from a headache and increased intracranial symptoms, as we stated before. Subarachnoid hemorrhage, severe headache, and after that, the patient started to vomit and suffering of nausea. And before it, severe attack of headache. Sagittal sinus thrombosis, progressive headache with increased intracranial symptoms, and there are risk factors as we stated before. The idiopathic increase intracranial tension, what are the risk factors of it to pick up this diagnosis? It's mostly in females, okay, mostly in the obese patients, or the patients who started to receive medicines like vitamin A, derivatives of vitamin A like isotretinoin, tetracycline, steroids, oral contraceptive pills, or it may be secondary to obstructive sleep apnea. So you should ask about drugs and ask about weight changes. All of this is very important. And idiopathic increase intracranial tension, the headache is more at the morning. The investigations you would like to do for increased intracranial tension headache, first of all, by doing an image like CT to look for any mass bleeding, all of this, MRI and MRV to exclude any blood clots in the brain veins. Golden standard is measuring the CSF pressure by lumbar puncture, which is the golden standard for idiopathic increased intracranial tension. Please don't use the term of benign increased intracranial tension, because it is not more benign. It is a headache which on the long standing may lead to blindness. Okay. The treatment of idiopathic increased intracranial tension is lifestyle modification, reduction of weight, stopping of the offending medicine if found, like vitamin A, tetracycline, isotretinoin, steroids, oral contraceptive pills. All of this very important to stop it. Doing of recurrent lumbar puncture sessions to decrease, which is one of the important treatment cornerstones. If the patient refuses, we can use a medicine which is called acetazolamide, but lumbar puncture drainage is more successful than using of acetazolamide. If the patient is in chronic stage or not responding, so at that time we will go for surgery by doing a ventriculoperitoneal shunting. Giant cell arthritis. Giant cell arthritis, one of the major topics that you may find in your um, case. Okay, usually the patient is 50 years or above. Don't think in it in a patient young age, because the examiner at that time will not be satisfied by this diagnosis anymore. Okay. The cause of it is the starting of an inflammatory process affecting the temporal artery and may go for the ophthalmic artery, which is supplying the retina, and involve it also. There are also symptoms of polymyalgia rheumatica, which is a big clue. You should ask him about any problem in raising of your arm, any arm stiffness. Do you feel any problem in standing up from a chair? Do you have any problem in combing of your hair? All of this considered to be very important clues about polymyalgia rheumatica, which is highly associated with this problem. The manifestation that the patient may suffer from is severe headache with a tenderness present on a side of head. Maybe there is a fever. There is a fever. Okay, presence of fever with headache. The most important differential is meningitis, encephalitis, also in giant cell arthritis. Some patients, not all patients, subarachnoid hemorrhage may start their body temperature to elevate. Okay, so these are the most important to know about fever with headache. Claudication while movement of his jaw or chewing the food is very important. Scalp tenderness, unilateral visual symptoms. This means that if there is an eye pain or a decrease in the visual acuity, so this means there is an eye involvement, and it is a very dangerous sign to start the treatment early if you are suspecting involving of the eye. Start high dose steroid. Giant cell arthritis criteria: you should have 3 out of 5 these features. If it is present and you have at least 3 out of 5, so it is a high probability that the case may be a giant cell arthritis. First of all, age more than 50 or more, equal 50 or more. ESR 50 also. New onset of headache. If you press the temporal artery for a patient, you will find a tenderness on palpation or there is a decrease in pulsation. Temporal artery biopsy, but you will not ask for the biopsy for sure. The rheumatologist, who is a person who will ask for this temporal artery, and if the results of this temporal artery came with an abnormality, so this means affection of the temporal artery, and it can be a criteria of the giant cell arthritis. What are the investigations you would like to do for a patient with a suspected giant cell arthritis? First of all, ESR is highly important. Doing Dopplex on temporal artery, MRI. Also, MRA may be needed to look for the blood vessels. and temporal artery biopsy, but the biopsy will be asked by specialists and the advanced imaging. The treatment is an urgent admission for the patient, starting with a high dose steroid 60 mg prednisolone and continue for 1 month if the case confirmed. Aspirin 81 mg, which is a low dose aspirin, is very important, and referral to a rheumatologist and multidisciplinary team, which is very important. Analgesic abuse headache, one of the common scenarios that you may find. It is a patient who is receiving a high dose or a frequent usage of non-steroidal anti-inflammatory drugs or paracetamol, which considered all of them are analgesics um, for headache, and he is receiving them frequently, and according to the criteria of it, a patient at least using it day after day. So if we calculate it, it will be at least 15 days per month uh, for more than 3 months. So if you found a patient who is receiving analgesics more than frequent for a headache, and this headache is coming with using of analgesic or recurrent with using of analgesic, so at that time you will think about the analgesic abuse headache. But the clue here is receiving analgesic in more frequent time and a lot of times, especially per month. Okay, and the headache may come again for the patient even with using analgesic, because he will need a higher dose, and we call it rebound attack or a rebound phenomenon of this headache. So at that time he will need another high dose of analgesic. The clue here is receiving analgesic more than usual in a high frequent time. Tension headache. Tension headache, it is the most common headache in all types of headache. All of us suffered before from a tension headache during exams or before the exams. Okay, so tension headache, it is the most common type, and usually tension headache increases at the end of the day. The criteria of it, it is a band like and may remain for days or week. Okay, and the clue here is stresses is very important thing you should ask about. Do you have stress in work, stress in your social life, stress in your financial support, and all of this you should explore about stress, and you should offer for him help. Offering help is very important in this situation. Thank you all doctors, and I hope that I covered all the clues and the most important ideas in this topic, which is extremely important. And also I hope to meet you again in another session with very important scenarios that you can find in your exam. Thank you.